Advanced Neurosciences Institute in Franklin, Tennessee is hosting this NeuroNexus event. I'm joined here by Dr. Samuel Hunter and by Dr. Jonathan Cockwood. When people talk about treating MS, there seem to be different ways of starting low or starting high. What are general approaches to treating MS? What are those approaches, Dr. Hunter?
Well, the big classifications and difference, both in what's been done in the past experimentally and what's done in practice, are called treatment escalation versus induction therapy. And treatment escalation is the more common paradigm because we're generally starting with medicines that have been tested and shown to be safe and effective at the first treatment for MS. And these drugs usually have a very good safety profile, a very well understood way to assure their safety. Whereas drugs that are higher risk, higher efficacy can be used for people with extraordinary bad prognosis or worse indicators for potential prognosis, disease activity, early disability as a first treatment. Many times we run into problems with payers in getting that approved because payers want cheaper, older drugs to be used first, and sometimes that's just easier to get someone to fail that. And while we don't like to give people the worst drugs, sometimes we can spend more time arguing with the payer than it takes to actually show that something doesn't work. So it's easier to just go ahead and do the step therapy. Lots of options open up if somebody's not done well with a frontline therapy.
Dr. Cockwood, people have heard this term induction therapy versus the idea of escalation or step therapy. What makes sense?
Well, first of all, I think the terminology is a little confusing. The term induction therapy is actually something that was developed as an approach to treat cancer. When we talk about induction therapy, there really isn't a platform escalate or induction. There's a middle ground. There's starting with the platform and escalate using lesser efficacious, lesser effective treatments to start with that presumably are safer. And then if there's breakthrough disease, worsening of disability, relapses, MRI changes over time on the initial treatments, we step up, move up a step, and then finally we would go up to the strongest treatments. Now that's a platform and escalate approach, a step therapy, if you will. Induction therapy would be something like the HALT-MS study that used massive doses of chemotherapy to wipe out the patient's immune system, gave them back bone marrow, essentially so they wouldn't die of overwhelming infection, and we managed very good success rate in that trial, unfortunately with a 4% mortality rate. So on the one end, induction therapy is potentially risky. This middle ground of using high efficacy treatments very early in the disease course seems to be maybe a middle ground between taking more risk versus lesser efficacious therapies, where the risk you're really taking with those therapies isn't necessarily the risk of the treatment, it's the risk of the disease. So whenever we talk about risk, regardless of what level of treatment we're using, it's always this balance. What's the risk of the disease? What's the risk of the treatment? And that's important to understand.
When we look across the world, and even when we look across the United States, we're still not seeing complete agreement in terms of whether it makes sense to start out with what we call lower efficacy or less strong medicines and move upwards, or whether it makes sense to start on what we think of as the highest efficacy or the higher efficacy medications and go from there. And because of that unanswered question, that's allowed other people to make those decisions. So there's not just the patient and the care partner in the room, not just the neurologist, the nurse practitioner, physician assistant in the room. There's obviously the person who pays for the care as well. And so the payer or the insurance carrier a lot of times is going to set what those parameters are. And for many of those insurance carriers, what it's going to mean is you're going to start on something with a little bit of a lower efficacy potentially, not one of the newer medicines, and start those medicines first. And if you have a problem, can you move to those other types of medications? I think we're seeing more and more research that's helping us answer the question. The problem is that different people are really different. Mm-hmm. Some people want to take chances, and other people say, no, I want to go on something that's been around for the longest time. And so what that means is for as long as different people have different choices, it means we're not going to have a full consensus on what makes sense. Research is continuing, but it's still an unanswered question. I want to thank you, Dr. Jonathan Cockwood. I want to thank you, Dr. Samuel Hunter. I'm Dr. Daniel Cantor. Thank you, Advanced Neurosciences, for hosting this NeuroNexus event.